I'm always thinking about my tribe here at the Thriving Urology Practice Facebook group, and today is no different. Every time I see a patient, I see an E&M example, I'm thinking, gosh, I need to share this with everyone because of the thought process behind E&M. I'm going to take an example of a scrotal pain patient whom I saw recently and then use it as a platform to explain a particular E&M level that I reached. And if you agree, disagree, please let me know in the comments. And yes, I'm still working on a Q&A session for E&M, for urology. I've come up with an introductory slide deck, which is going to be very cursory to go over the ground rules. And I also modified an E&M medical decision-making table to make it easy and hopefully very concise. So on one screen, you can look at how the decision-making is going to be made so that you can bill appropriately. So anyway, scrotal pain, which is something that we as urologists see all the time, and it can be the E&M level can vary depending on what is actually done and also the documentation that you provide. So recently, I saw a gentleman in his 40s who comes in with a multi-month history of right scrotal pain that is intermittent. He has no new sexual partner, no signs and symptoms of STI, no dysuria, gross hematuria, no signs of infection, no trauma or anything like that. So he comes in complaining of scrotal pain. Of course, not unusual. He already saw his primary care who ordered an ultrasound of the scrotum, which demonstrated normal right scrotal contents and testis, and an incidental finding of a left spermatocele. So now we're dealing with right scrotal pain and left spermatocele. Okay, so the patient comes in, and of course my staff always gets the outside imaging report and everything like that before the patient even gets here. So by the time the patient gets here, I have already gotten the imaging and also the report, the actual images and the report. Patient's ready, placed in the room. Before I walk into the room, I have already reviewed the outside records, including personal review of the scrotal ultrasound images. So I already saw the 1 centimeter left spermatocele located at the globus major on top, and also the right scrotum and contents are normal. As usual, there's a little bit of hydrocele on both sides. Who doesn't have a hydrocele? Small amount of hydrocele, right? You're supposed to have a little bit of fluid around the testicles. So anyway, right side on ultrasound is normal, left side spermatocele. I go in, examine the patient, everything is normal, document the necessary examination, clinically relevant examination, and then comes now we have medical decision making. So I'm dealing with two different problems. One is chronic scrotal pain that is not bad. I asked the patient, do you want to be on pain medication? Do you need further evaluation? Do you want to do anything further to try to figure this out? He said, well, no, things are slowly getting better, but is lingering. I'm going to decline out the pain medication, the prescription pain medication. So I recommended self-examination. I recommended NSAIDs, ice, scrotal support, rest, the usual non-specific scrotal pain recommendations for the right side. Now, that's a chronic problem. And what is a chronic problem, right? So I think that this is a chronic problem. That is my determination. That is my documentation. This is a chronic problem that is stable. Stable chronic illness is a problem with an expected duration of at least a year or until the death of the patient. Chronic conditions treated regardless of stage or severity of changes. Stable is the specific treatment goal for the patient. It is stable. I'm not prescribing medication. I'm not doing any additional imaging. So I think it's stable. Unmet, unchanged treatment goals with no short-term threat to life or function are not stable. So this is a stable chronic problem, most likely. Okay, I don't know if it's going to get better. I don't know if it's going to get worse, but we're simply going to observe. Recommendation is over-the-counter medication, which is a level 3 risk. We're going to talk about that in a second. So the problem for this right scrotal pain is chronic, stable. Okay, now let's talk about the spermatocele that I found on examination and also was documented on the scrotal ultrasound. I personally reviewed the scrotal ultrasound. So that's something we need to talk about. From a problem perspective, a spermatocele is likely going to be a chronic problem. It may get bigger, it may stay the same, usually it doesn't go away. is likely going to last the duration of the patient's life. So this is a chronic problem. It is stable. It is not causing any issues. I do not think this is a self-limited or minor, because the definition of a self-limited or minor is a problem that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. It is definitely not transient. It is likely going to stay there forever, and it may get worse. Granted, it may not permanently damage or alter the health status, but it is not, in my interpretation, it is not a self-limited or minor. It is a chronic stable. So now we have two stable chronic issues, right scrotal pain and also left spermatocele. Okay? So 4 and a 4. If you just have one stable chronic, that's a level 3 problem. Okay? Level 3 problem. If you have two stable chronic issues that you're dealing with, two stable chronic problems that you're managing, it is a level 4 problem. It is a moderate complexity problem. Okay? Not level 4 E&M, but a moderate complexity problem, level 4 problem. So two stable chronics equal level 4. That is something that is missed by a lot of people, including the AUA. When they first did the explanation of E&M levels, it was not even mentioned on the handout or in the explanation video that they did. But anyway, if you're managing the problem, if you're doing the work, write it down, document it, and bill appropriately. So this is the level 4 problem. So as you know, medical decision-making requires 2 out of 3. What are the 3? It's problem, data, or risk. So I only have problem that's a level 4. Well, let's look at data and risk. When it comes to risk, I'm not recommending any surgery. The only thing I recommend is maybe over-the-counter NSAID. So that's a level 3. That's a low-level type of a risk, which is a level 3 risk. So now I have a level 4 problem, a level 3 risk. At most, it's only a level 3. But wait, as they say in the commercials, there's more. What about data? What did I do? I summarized, obviously I looked at the outside records. I summarized, didn't summarize it, but I looked at the outside records. So that only gives you 1 point in category 1. So you need multiple points. You need 3 or more to even get a level 4 in category 1 data. I only have 1. Okay, fine. Urinalysis, which is normal. Okay, 2 points. Still, that doesn't give me up to a level 4 in category 1 data. I only have 2 points, and I need at least 3 or more of category 1 data to give me level 4 in data. However, what did I do? I independently reviewed the scrotal ultrasound images. And unfortunately, we have to play this stupid game of, even though we did the work, we now have to write it down, which is total ridiculous. I totally get it. We are being gaslighted into thinking that this is the normal way of doing things, that we have to do this, jump through all these hoops just to get the paltry amount that we get paid. And we are being gaslighted by third-party payers that we are not worth as much as we need to be paid. We should be paid. I totally get it. But if you want to play the third-party game, unfortunately, you have to play by the rules. Otherwise, you can go concierge and go cash. Unfortunately, most Americans, most humans, don't plan ahead, so they don't save money for that rainy day. I mean, look at what happened in 2020, right? So we have a level 4 problem. We have a level 3 risk data section. I independently review the images. So guess what? That's independent interpretation of tests performed by other professional. That's 1 point in category 2, which qualifies as level 4 data. So now I have level 4 problem, level 4 data, and level 3 risk. That's a level 4 E&M visit, 99204. Okay? Now, when it comes to an audit, how do you demonstrate that you actually independently review those images? Well, I recommend that you consider documenting in your chart that scrotal ultrasound from insert name of imaging center performed on insert the date of performance was reviewed by me, or reviewed, period. Or if you show the patient scrotal ultrasound from imaging center name on date was shown to and reviewed with the patient. right? So there's no doubt that you independently review these images. And obviously, if you agree, disagree, or if you notice something that is different than the report, you obviously would document that. But I think most concisely, to audit proof your records, that is probably right now, as far as we understand the rules, right now, that is probably the best way to show that you independently review these images. Okay, so let me know what you do. Let me know what you think to document independent interpretation of outside images, other outside tests. I know recently there's a CMS Q&A session that was carried out, and some of the medical directors may have mentioned that you have to not just personally interpret it, you have to document it, then you have to talk to the imaging center's radiologists, and then write that you disagree with the interpretation. No. Unless it's in writing from CMS or from CPT panel, AUA CPT, AMA CPT panel regarding these test interpretations, I'm going to go by what's written. Often, the answers given by some of the medical directors and presenters and consultants is contextual. It depends on how the question is asked, and also the perceived understanding of the person answering the question. So make sure that you get it in writing. Everything that is just written, that is just verbalized, it's just hearsay. If you look at the documentation from CMS, they always go back, most often than not, always go back, refer you back to look at the AMA's interpretation, AMA's characterization of the rules, the CPT panel, the E&M panel. So make sure that you look at the AMA E&M rules, and make sure you look at the March 2021 technical updates, because that clarified some questions for everyone relative to E&M 2021. Okay, so lots of potential ambiguity for people, but look at what's written down in writing, and don't worry about what someone else may have said. If it's not in writing, it is very difficult for somebody to reinforce. That's why I always go back to the documentation in the medical record and also in the E&M's explanation of the rules. All right. So once again, let me know if you agree, disagree, or if you think that I'm full of it. Let me know what you think regarding this particular scenario. And obviously, this is a clear demonstration of the importance of documentation. If you wrote it down, then I can justify, right? If I wrote it down, I can justify billing and coding for this level. But if you don't write it down, you assume that your auditor is going to say that, well, I'm going to assume that the provider looked at the images. That ain't going to fly, okay? So you may be subject to clawbacks, takebacks. So keep in mind, documentation is key. Unfortunately, we've harped on this forever. So try to find ways to make your life easier by having a scribe, virtual scribe, in real life scribe, or using voice recognition to make sure your documentation is absolutely complete and concise. Lastly, I am going to remind you, yes, I'm going to work on the E&M Q&A that will definitely have happen within the next few weeks. And once I finish the slide deck for a very brief presentation, and then we'll definitely go into the Q&A so that we can all benefit and learn from each other, because I'm still learning. These rules have only been implemented for less than 9 months. So this is very, very new. And keep in mind, the last set of E&M rules came out last time it was updated, it was 1997. So 20 some odd years, almost 25, 26 years, depending, 95 and then 97. So a long time. It did not change for a long time. And this set of rules is going to get modified, get evolved, because there are always unintended consequences when you make E&M rules. Some people are going to try to figure out what is the best way to do things, what is the right way of doing things, and sometimes what you think is going to happen doesn't always happen the way the CPT panel thinks that it's going to happen. So there's always going to be confusion. Anyway, as usual, comments or questions, leave them below. I look forward to hearing from you. Take care. Bye-bye.